حاجه التليفون مش شغال.
اوكي.
اوكي لا عشان لا يا حبيبي مش الاسئله هتجاوب لا الكسندريا بس يعني. بسم الله الرحمن الرحيم. سوري في التاخير بدايه السيشن. ده حاجه خارجه عن ارادتنا عشان الفيديو كونفرنس. برحب بيكم كلكم. ويلكم تو اور جيست professors and colleagues. And welcome to our dear Professor Dr. Magdi Ibrahim, our chairman. There is some modification in our session. I will begin with the title of serum interleukin 6 and umbilical artery Doppler in the pre-eclamptic patient by Dr. Salih Abdeltawab, Alexandria University.
شكرا. بسم الله الرحمن الرحيم. Good morning, everybody. At first, I would like to thank the organizing committee for their giving me the chance to present today my titled topic. And at the same time, I would love to invite all of you to our annual conference at the start of May in Alexandria. I am sure you will enjoy the conference and you will enjoy the weather in Alexandria, and it will be a good, nice experience. And by the way, I would like to tell all of you, this is my first time to go out of Alexandria here in Egypt to attend an Egyptian conference, although I have traveled a lot in Europe and America, but I get to the point that it is time and is a priority for all of us to exchange our local experiences of research. The study was conducted as a master thesis 1.5 years ago, and the working team was Dr. Medhat Anwar, Dr. Tariq Arur, and Dr. Akram Deghidi, and me as Salih Al-Tawab. To start with, interleukin-6 is a pro-inflammatory cytokine produced by mononuclear phagocytes, endothelial cells, fibroblasts, and T cells that may have many functions and effects. Interleukin-6 may increase the permeability of the endothelial cells by changing the cell shape and rearrangement of the intercellular actin fibers. Little is known about the relationship between the severity of inflammation and the severity of preeclampsia due to the insufficient reports investigating this matter, and this sentence was referenced for a recent in maybe 2011. Up to the moment, in spite of all the investigations of preeclampsia, we are still saying that there are issues which are not settled and still needs research. The aim of the study was to compare between changes in the maternal serum interleukin-6 as a pro-inflammatory cytokine, as I have just mentioned, and the changes that happen in the umbilical artery Doppler velocimetry in preeclamptic patients. We recruited 20 women aged between 20 to 40 years at a gestational age 32 weeks or more with a single pregnancy, singleton fetus. Exclusion criteria was age less than 20 and more than 40, multiple pregnancy, diabetes during pregnancy, hypertension diagnosed before 20 weeks of gestation, pregnancy complicated by conditions such as pyelonephritis, thyrotoxicosis, or chromosomal abnormalities, and patients with other obstetric complications such as placenta previa. In our study, the recruited women were divided into 3 groups, and actually we selected the group according to the criteria of preeclampsia. So we had Group 1 or Group A, which included 40 patients, and these are women with severe preeclampsia, of course, because of the blood pressure measurement of the degree of proteinuria. Group B included also 40 patients with mild preeclampsia, and Group C, 20 patient pregnant women as controls for a normal pregnancy. Measurement of the maternal serum interleukin-6 was done. The measurement was at the gestational age of 32 weeks or more, as we have said, in cases and control. The peripheral venous blood was taken in an Edita tubes, and then the plasma was spanned for 30 minutes to remove the particulates, and then it was stored as usual. Of course, the umbilical artery Doppler studies were done, and the measurements was taken. Our results. At start, when we compared the 3 groups as regard the age of the patient, there was statistically significant difference, and this, to my mind, of course, was due to the normal variation between severe preeclampsia and mild preeclampsia. As regard the age, the more younger group is more liable to have a severe attack, and this is one of the different studies always found that. The interleukin-6 was higher in severe preeclamptic group than in the mild preeclampsia. and the control groups with statistically significant difference. Again, it was higher in the mild preeclamptic group than in the control group with statistically significant difference. As you see here in the table, you will find that the interleukin-6 levels was higher in the severe preeclamptic groups than in the mild, and the mild was higher than the control group. We tried by statistic to analyze, is there a cutoff level below which we can differentiate between cases and control? Actually, by doing the ROC case, the ROC curve, as you will see in the next slide, we found that the cutoff level of 0.82 nanogram per deciliter can be used to diagnose early preeclampsia. And this showed us that 87.5% of the cases with a serum level of levels more than this, and only 12% with a level of serum less than this can differentiate between the cases and the control. Then this is the ROC curve as I'm showing you here, and you have found that at this specific serum level of interleukin, and this was showing the specificity and the sensitivity at this cutoff level wasn't low, it was high. Again, we tried to see, is there a cutoff level between mild and severe preeclampsia as regard the interleukin level? Also, another cutoff level of 1.18 nanogram per deciliter was found, and give us a sensitivity and specificity of 100%. Comparing between changes in the umbilical artery Doppler indices and the maternal serum interleukin-6 in the 3 studied group, we found that there was a statistical significance correlation between the interleukin level changes and SED ratio and interleukin-6 and resistant index in severe preeclampsia, while there was no significant correlation was found between the changes in the interleukin level and the Doppler studies in women with mild preeclampsia or in the control group. And these were our figures. And this is the graphic presentation of the table. As you see in green color, which is high up, and apologize me for not presence of the pointer, you will find there was a significant correlation between the interleukin levels and the pulsatility index in women with severe preeclampsia, while this significant correlation couldn't be detected in women with mild or controlled pregnant women. Our conclusion of the study, maternal serum interleukin-6 more than 0.82 nanogram per deciliter can be implicated as an early laboratory diagnosis of mild preeclampsia. The significant correlation between maternal serum interleukin-6 levels and Doppler velocimetry in severe preeclampsia support both the immunological and systemic endothelial dysfunction theories of preeclampsia. And thank you.
Thank you so much, Dr. Sally, for this constructive and very valuable talk. Let's proceed to the second talk.
Our second talk is about hypermethylated RASSF1A in maternal plasma as a non-sex-dependent marker for monitoring of preeclampsia. We all know that monitoring of preeclampsia is a very important and an interesting issue in our obstetric life. Dr. Sameh Salama from the National Research Center will talk about this.
Mr. Chairman, ladies and gentlemen, thanks for offering me the chance of being here today. In the last few years, in my department, in the National Research Center, in collaboration with some of the Egyptian universities, we start directing a big part of our research towards what's called molecular biogenetics. And as shown in this presentation, we have studied the relation between what's called RAS1A gene as a non-sex-dependent marker for monitoring of preeclampsia. A gentle reminder on preeclampsia is one of the most serious pregnancy complications worldwide. 3 to 8% of pregnancies would be affected, and it is responsible to nearly 18% of maternal death and up to 40% of fetal mortality. Still, in 2015, we lack a safe and effective therapy as well as a reliable early means of diagnosis or prediction of preeclampsia. Preeclampsia is defined as a new onset hypertension presenting after 20 weeks with significant proteinuria. Severe preeclampsia, in addition to the classical definition, it's a significant proteinuria exceeding 2 grams, sometimes they say 5 grams, in addition to biochemical and hematological impairment. The well-known dictum, prevention is better than cure. However, it's not always reachable. Many agents have been studied for the prevention of preeclampsia: magnesium, folic acid, antioxidants, nitric oxide donors, progesterone, diuretics, and heparin. Unfortunately, the evidence for all those medications are varying. Some studies could advocate their use, however, the overall evidence is still weak. I think many of the obstetricians think that low molecular weight heparin is the magic bullet that can cure everything for a pregnant woman. However, still it is not free from complications and needs a special follow-up, and it's convenient for the patient to convince her to have a daily injection for 9-month pregnancy. Interestingly, aspirin, one of the cheapest medication in the Egyptian market and worldwide, gave the best results. Different studies, 50% reduction, 20% reduction, 30% reduction in the rate of preeclampsia, but still you cannot figure a definite number. The question is when and who deserve to have aspirin. Again, it's a convenient medication, well tolerated, but it's not free from complications. So according to the NICE guidance 2011, any patient with hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disorder, diabetic or chronic hypertension should receive or should be offered aspirin throughout her pregnancy. If you have 2 or more of any of those risk factors, first pregnancy, age above 40, interval of pregnancy more than 10 years, BMI 35 or more, family history of preeclampsia or multiple pregnancy, still she should be offered aspirin. When to start and when to stop, still debatable. Some would advocate starting aspirin once the pregnancy test is positive. Another, you can start at 12 weeks, to stop at 37 weeks. Some institutes would carry on with aspirin till the day of delivery. I think it depends on the obstetrician assessment. If you think your patient is high risk for bleeding or something like this, you can stop at 37 weeks. At least if we cannot prevent preeclampsia, we are trying to predict. Many markers have been studied, still the evidence is not robust. So plasma-associated PAP-A, hemoglobin, fetal hemoglobin, placental protein 13, placental growth factor, cystatin C, interleukin-6 as mentioned by my previous colleague, but still there is no consensus which one to use. Cell-free fetal DNA. I mean, this is a very complicated issue, so we are trying to simplify things. So maternal plasma has both maternal and fetal DNA. Maternal DNA, which is normally present in her blood, and fetal, the source is the fetus and the placenta. It is stable, high concentration in maternal plasma. The good thing, it's rapidly cleared up from the maternal circulation after birth, probably within minutes to hours. It is circulating, it's released, as I'm saying, from the fetus and placenta due to the process of apoptosis. In preeclampsia, there is, as we know, the pathogenesis of preeclampsia is impaired trophoblastic invasion to the maternal spiral arteries. This will lead in turn to placental ischemia and release of necrotic or apoptotic syncytial trophoblasts, which in turn have the DNA or fragments inside it and will release it to the maternal circulations. Still, it's not easy to separate the fetal DNA, different challenges, the sensitivity. It can be early detected in the maternal circulation, possibly from 4 weeks, reaching a detectable level at 7 weeks. But practically speaking, for a lab, an Egyptian lab to detect it, I think 10 weeks or more. So if you're trying to detect before 4 weeks, you will get an error or a false negative or positive, whatever the result. Still, it's found in a good amount, can be detected, but if compared to the whole maternal DNA, it's low in amount. Dynamic range is something related to the lab work. Lack of reliable specific marker, and it cannot detect everything, so it's only detect some fetal DNA sequences that is paternally inherited because the mother and fetus share on average half of their genomic DNA. Why we use or prefer to use cell-free fetal DNA instead of fetal cells? The advantage of cell-free fetal DNA, it's present in large amount, it is rapid, reproducible, and the sample can be frozen and archived. And it reflects definitely the current pregnancy because it will break in the maternal circulation within minutes or hours, as we mentioned. This advantage is only limited to unique fetal genes and sequences. On the other hand, fetal cells can be used to diagnosis of aneuploidy, in situ assessment of tissues, can be performed by the FISH or PCR, and the problem with contamination is less. On the other hand, it's low in number, and a separation method is needed. And the most important, it lasts for a long time, up to 27 years in the maternal blood. So it can give you, I mean, if the patient is not a primate and she had a previous pregnancy, it will give you some sort of error. In our study, we recruited 120 cases, more than 28 weeks. We divided them into a study group. Another 60 represented the controls didn't have preeclampsia. The 60 who has been diagnosed with preeclampsia subdivided into 30 with severe preeclampsia according to the criteria, and 30 with mild preeclampsia. We took a peripheral blood sample, and the DNA was extracted and studied in the lab. This is the RAS gene we are talking about. Again, to simplify the things, every one of us will have this RAS gene on his DNA or her DNA. So the mother will have the RAS gene, and the fetus will have the RAS gene. But the difference is in the maternal blood, it will be hypomethylated. In the fetus and the placenta, it will be hypermethylated. In other words, it will be protected by a methyl group against cutting by restriction enzyme. I think it makes it an ideal target for us to study. So if you get a blood sample from the mother and applying a restriction enzyme, it will cut the maternal DNA and it will leave the fetal DNA, and by this way you can count it. So again, it's based on the detection of hypermethylated placental DNA or fetal sequence in maternal circulation. The methylation pattern of RAS promoter in the placenta and maternal blood allow the use of methylation-sensitive restrictive enzyme for detection. This is how it goes in the lab. I think it's not an easy, I mean, I'm not expert in lab work. It's a bit complicated, but this is how it goes. They got the sample, possibly centrifuging and separating cells. At the end, they give us the cell-free fetal DNA. After analyzing our data, what we found, we compared the demographic data for the studied groups, maternal age parity and gestational age. The difference was not significant, which I think is logic. When we compared the copies or the mean value for free fetal DNA in the controls, mild and severe preeclampsia, there was a significant difference between the controls and mild preeclampsia, again between the controls and severe preeclampsia. We further compared the mild and severe, and what we found is there was a significant difference between the level of cell-free fetal DNA between mild and severe cases only in the primates, not the multipara. I'm not sure what's the explanation, but it could be something related to the immunological reaction of the primates towards the fetal. It's the first time to be exposed to fetal cells, so it could be the immunological reactions is higher. So, as any screening test should fulfill a certain criteria, central role in the pathogenesis and of the disease and be specific for the condition. This is not the case in RAS. Appear early and before clinical manifestations, easy and cheap, high sensitive and specific, correlate with the severity of the condition, and this is proved in our study, to be non-detected or expressed at very low levels in normal pregnancy in order not to be misleading. In conclusion, the administration of quantitative aberrations of hypermethylated RAS in maternal plasma represents a potential useful, non-invasive approach which is gender and polymorphism independent. When I'm saying it's gender independent, initially to detect a fetal DNA, you can use the SRY gene, which is specific for male fetus. So if the patient is pregnant in a female fetus, you cannot detect it. So this marker is not gender dependent, and this is very important. To be honest, I'm not here to saying that we need to investigate such possibly an expensive investigation just to diagnose preeclampsia, which can be diagnosed only on clinical basis and some cheap labs. But we started by this study, and after this, we developed the research to correlate it with the Doppler, giving a cutoff limits, and this will be presented by my next colleague. And now we are starting another research. We are trying to detect the fetal DNA early in pregnancy to work as a predictor, not a diagnosis. So finally, clinical utility of this approach would need to be assessed in earlier stages of pregnancy in order to be investigated as a predictor of preeclampsia. Thank you.
Thank you so much, Dr. Sameh, for this interesting presentation. Let us proceed to the third talk under the title of Plasma Circulating Cell-Free DNA and Uteroplacental Blood Flow in Preeclamptic Patients by Dr. Sherif Sergani from the National Research Center. Dr. Sherif.
Assalamu alaikum. My talk about the plasma cell-free fetal DNA and the uteroplacental blood flow in preeclamptic patients. Preeclampsia, it's a condition of in pregnancy characterized by hypertension, proteinuria, and edema in hand, and face after 20 weeks. But it has been recently changed according to Task Force 2013. We can diagnose preeclampsia even in absence of proteinuria or edema. Preeclampsia is considered the most common complication of pregnancy, and it complicates about 5% of pregnancies. The complications include the mother and fetus, mothers such as eclamptic seizures, intracranial hemorrhage, pulmonary edema, and fetus such as accidental hemorrhage, intrauterine growth restriction, or even intrauterine fetal death. The pathogenesis of preeclampsia, it is considered a disease of theories. One of these theories is placenta, which is affected by preeclampsia, shows ischemic damage with maldeveloped terminal villi, which leads to release of DNA into intravillous spaces, which released into maternal circulations. Many researchers focused on isolation of fetal cells and free fetal DNA in the maternal blood. However, the fetal cells can be still present in the maternal blood for years. So it is not reliable for diagnosis of any disease in the current pregnancies. The cell-free fetal DNA can be easily, rapidly cleared from the maternal circulations after childbirth. We can detect free fetal DNA from the 4th week. However, it is reliable from the 7th week. Many reporters confirmed that cell-free fetal DNA correlates positively with the gestational age. There is 3 sources of free fetal DNA in the maternal blood: direct transfer of DNA, or even placental origin, or hematopoietic cells. The clinical application of cell-free fetal DNA, we can detect the fetal sex to define or diagnose sex-linked disorders such as hemophilia. It has an important role in some endocrine disorders such as congenital adrenal hyperplasia to prevent the development of congenital ambiguous genitalia if the fetus is female, by giving the mother of dexamethasone, high dose of dexamethasone. We can diagnose single gene disorder, dominant single gene disorder such as achondroplasia or even recessive single gene disorders such as beta thalassemia. We can diagnose Down, the Edward and Pateau, all aneuploidies. Also, we can diagnose preeclampsia, intratrunk growth stricture, and preterm labor, and detect the fetal RH. The detection of cell-free fetal DNA from the maternal blood can be done either by detection of Y chromosome if the fetus is male, and another method is hypermethylation. There is a certain genes in the, which is hypermethylated in the fetus. This gene is promoter RASP gene 1 or MASPIN gene. We used two kits for this maneuver. One kit for detection to mark the genes, and the other kits for isolation of free fetal DNA from the maternal blood. Several studies reported that the free fetal DNA level increased 2 to 15 folds higher in the preeclamptic patient than normotensive pregnant woman. The level increased according to severity of preeclampsia. The mechanism we thought that the free fetal DNA increased in the preeclamptic patients due to placental hypoxia, which lead to placental apoptosis and necrosis and the release of DNA into intervillous spaces, or destruction of fetal nucleated cells such as erythroblast, and reduce the clearance of the free fetal DNA from the maternal blood. In our study, we want to evaluate the free fetal DNA in preeclamptic patients during third trimester and to detect if there is a correlation between it and uteroplacenta blood flow. 120 pregnant women were included in this study during third trimester. 60 was normotensive as a control group and 60 as a preeclamptic patients. We all are subjective to full history taking and general and local examination. We excluded the fetal anomalies by mid-trimesteric scan. All are subjected to fetal biometry to exclude IGR. And the Doppler study was done. And maternal blood sample for detection of free fetal DNA by methylation. Our results, according to demographic data, didn't show any significant difference in the gestational age and the maternal age. According to the box plot figures, the free fetal DNA level was much higher in the preeclamptic patients than the normotensive patients, and the difference was statistically significant. The median of the plasma cell-free fetal DNA in preeclamptic patients was 146 copies per milliliter, and the mean was 199 plus or minus 160 standard deviation. The cell-free fetal DNA increased about 3.8 folds in the mild preeclampsia and 11.3 folds in severe preeclampsia. According to the ROC curve, we found that the plasma cell-free fetal DNA sensitivity was 99% for detection of preeclampsia, and specificity was 97%. And the best cutoff value during third trimester was 80 copies per milliliter. According to correlation between cell-free fetal DNA and uteroplacenta blood flow, we measured the umbilical artery PI and the mean uterine PI. And we found that there is a positive correlations, and the difference was statistically significant. We concluded that there is a positive correlation between plasma cell-free fetal DNA and severity of preeclampsia, and there is also a positive correlation with the uteroplacenta blood flow. In the future, we believe that, or we hope, there is we can use a cell-free fetal DNA as a tool for prediction for women at a high risk of